Thank you for the opportunity. So, I'm going to give an overview of how to start a robotic pancreatic surgery program. My disclaimer is some of the illustrations are prepared with the AI and the content is mine. So, the outline would be what are the essential requirements to start the robotic pancreatic surgery, the training pathways which a surgeon should undergo to start the pancreatic surgery, and the challenges which we can encounter during the initial phase. Before we actually go into the starting robotic pancreatic surgery, it's important to understand what is the current evidence with respect to the robotic distal pancreatectomy and robotic pancreationectomy. We also do robotic pancreatic surgery in chronic pancreatitis, but due to lack of good evidence, I'm not including that. So the focus would be on robotic distal pancreatectomy and pancreationectomy. So to summarize the evidence from the randomized trials, in distal pancreatectomy, you know that robotic surgery enhances the functional recovery compared to open surgery, increases the spleen preservation rate, and reduces conversion to open surgery when robotic is compared to laparoscopic. And in PD, the shorter hospital stay compared to open surgery, and it's between 1 to 2 days in most RCTs. So the clinical relevance is being questioned, and when compared to laparoscopic approach, the conversion is reduced. So if you see the evidence for robotic pancreatic surgery is not very strong, especially in pancreationectomy compared to the open. But despite the lack of strong evidence for robotic surgery, if you see the numbers, there is a wider adoption. The numbers are increasing globally, and possibly it is due to, I think, when you demonstrate the non-inferiority of robotic surgery compared to open, laparoscopy is different. So the patients are more willing to undergo the robotic surgery. That's probably one of the explanations. There are many other reasons. So that's the why I brought out this point is because there is wider adoption, the numbers are increasing, and more centers will be at least forced to start robotic pancreatic surgery. So it's important to understand how to safely adopt it. So the essential institutional prerequisites. One of the first thing we should remember is, unlike other surgeries, this is something should be started only in high volume center, because if we are going to do pancreatic surgery in single digit in a year, and it's almost impossible to give good outcome to the patients, and that's not really going to do well for both the institutions. So the first point to remember is make sure you start in a high volume center. Obviously the surgeon is the most important prognostic factor, so he should be well trained. And now we have multiple robotic systems are available, and I'm not going to talk in favor of a particular system or not, but it's well known there are some of the robotic systems are not good for multi-quadrant surgeries. So it's important you have the appropriate robotic surgical system with you. And the pancreatic surgery is more than the surgeon himself, so you need a good team for having a successful program. And the team should be mainly involve a good bedside assistant surgeon and a trained anesthetists who are used to, give anesthesia for long surgeries, and also need to have a trained nurse who will be able to assist you properly when there are complications with the appropriate instruments. And it's important, the initial phase, to have a consistent team and to ensure the better outcome, which is something very important, because you don't want the team members to keep changing in the initial phase, and then you need to train everyone. So the 5-step is something which can be adopted if you want to start this. One of the first step is, most of the, I've taken the Da Vinci as an example because that's what we are using. So you have, there are softwares which can be installed into whatever system you have. Even if you have bought the robotic system without the simulation software, we can request them. Actually, the company will install it even for some time, maybe without any additional cost. And you need to undergo the simulation training, which is must, because I've seen some of the surgeons directly start operating, and that can result in serious complications, and it's a strict no, especially for procedures like pancreatic surgery. The next is, you need to practice with tissues which are similar to pancreas. I think that's important, because while suturing and also while handling those tissues, you need to have, because you don't have any haptic feedback, it's purely a visual feedback when we do robotic surgery. I think one of the best the tissue is, either you can actually use porcine pancreatic tissue, but obviously in one pig you can get only single pancreas. So if you want to train many, you can actually even use the porcine muscle with a blood vessel. I think that's something which we tried when so Ramesh sir actually conducted one of the clinics, and we tried using that, and that's a good model. The muscle tissue with a blood vessel, that the muscle behaves like a pancreas, and those blood vessels are like a pancreatic duct. This is actually good tissue to practice pancreatic anastomosis. If you are going directly from open to robotic, the most important skill which need to occur is understanding the minimally invasive anatomy. So if someone has done laparoscopic pancreatic surgery, then it becomes easier, mainly because you are used to the minimally invasive anatomy. If you are not, and if you are directly moving from open to robotic, then it's important to see the unedited videos and get used to oriented to the minimally invasive anatomy. And then whenever you are starting the surgeries, it's always better to have proctors. I'm being a proctor for this robotic Whipples, almost close to 20 surgeons have proctored, and it's actually you get the real-time feedback, and that's very important, especially in procedures like Whipples, where you can go wrong in some of the steps, and you need to have a proctor when you do the initial procedures. And then you keep refining your skills by reviewing your videos and see where you have gone wrong, and that's important to maintain and improve your robotic skills. So I think that each of these various training protocol will have impact, like doing a simulation training will build your robotic skills, because getting used to how you can actually handle the camera, because this is something some of surgeons in fact find difficult to control the robotic camera, and that you get it from the simulation training. And standardized stepwise technique, that which I'll be discussing, which is the next important thing to keep in mind, because that gives a clear surgical roadmap. Then intraoperative proctoring allows you real-time corrections the video reviews, assessment reinforces the technique, and the focused reconstruction training will help in the challenging anastomosis. The next is the surgeon qualification. So it's imperative that because there are now some surgeries which you can actually start directly in minimal invasive, which is happening. Some hiatal surgeries, for instance, even esophageal surgeries. Many trainees start directly with the minimal invasive, and to some extent that's being more or less becoming acceptable, but not for pancreatic require a substantial experience in open pancreatic so that you understand how to manage some of the complications. And then the proficiency in robotic techniques, which includes both simulation and the tissue training, and followed by the animal, and then finally the cadaver. So you go through this before you start actually on the patients. Now this is where there's a lot of variability. The prior robotic experience, whether someone can directly start with robotic pancreatic surgery. If you see the West, there are units where the pancreatic unit, where the trainees actually start their initial procedures with robotic pancreatic surgery. They don't have experience in others. But in India, at least in majority of the centers, GI surgeons do perform other procedures. So it's a good idea to get trained yourself in other procedures so that you understand how to handle the tissue, how to control bleeding before you shift on to the robotic pancreatic. And even in pancreatic surgeries, you can actually start with distal pancreatectomy. Again, just to get used to it. But to me, more than doing the distal pancreatectomy, it is getting used to the hilar, the HDL lymph node dissections, so actually doing gastrectomies, and also getting used to the anatomy in the gastrocolic trunk, so doing some right hemicolectomy. So these are the procedures actually help you more than just doing a distal pancreatectomy, because distal pancreatectomy just gives you exposure to only one part of the procedure, but the other parts you will get experience from other robotic procedures. And then the standardization is something very important. The most important is standardizing your technique. It's not only the importance of standardizing your technique is your assistant will know during the critical steps how they should retract. Because unless they know what they are supposed to do in each step, the whole procedure can become messy, and that's where the problem starts. So the team should know exactly what will happen, and it's important to have meetings there prior. And also, this is one procedure, especially Whipple's, a good understanding of the good reading of radiology, and understanding what all vessels you'll encounter, so that, because in robotic especially you have a really zoomed in view, and if you are not reading the anatomy properly, you will get into trouble. So importance of, this is one procedure you should not do it just based on seeing the films, CT films, or from the CT report. You need to sit in the, if you don't have packs, sit with the radiologist, and this is very critical in minimal invasive, especially the robotic pancreatic surgery. And this is something which, that's one of the reasons why this publication is mainly to divide the procedure into multiple steps. And once you divide the procedure into multiple steps, your team knows what they are supposed to do during each step, and that really helps to do the procedure smoothly. Obviously, you will have challenges during the learning curve. I think the most important is you will have complications intra-op, which requires conversion. I think that's something which we need to be prepared, and the duration is going to be long in the initial phase. But the most important thing is never compromise on the targets which you are supposed to achieve during each step, because the moment you start compromise and try to find shortcuts, and that's not really help you in standardizing. So even if you are able to do only the gastrocolic trunk control in the initial case, still it's okay, rather than trying to use shortcuts like energy device and try to burst the vessels. That's something which should not be done. You will have challenges. The most important in any center with respect to robotic surgery is about the cost. I think various centers come out with their own models. I'm not going to the detail of that, but that's an important challenge which one needs to keep in mind. Extended operative time, that's definitely will be there, at least in the initial 20 cases, and the whole team should be prepared, including the anesthesia team. And you will have initially the limitations, and that's one of the common complaints which surgeon, when I do open or laparoscopy, I have the harmonic and vessel sealer with me, but the harmonic and robotic is non-articulating, the vessel sealer is still bulky, we don't have the synchro seal still in India, which is similar to the ligashore which we use in laparoscopic surgery. So there will be limitations, so we need to get used to techniques like double bipolar, and so that you can overcome those limitations. So this is just the experience at our center. So we started in 2018, end of 2018. So this is only the pancreatic surgery, that is distal and Whipple's. Then we had a dip during 2020 and 21 during the COVID, and then so roughly it's between the 25 to 30 per year with respect to the robotic surgery. I think the main challenge for us is the availability of the slots, because in fact that's the only challenge. There's no other, there's no issue of cost or the patients. So there will be challenge in each place. Some other institute will have other challenge, but something what we need to keep in mind is at least have a threshold of 20 cases per year. Otherwise, it's difficult to have a successful robotic pancreatic surgery program. So this is just summarizing the keys to program success, which includes the institutional commitment, team development, structure training, standardized protocols, and the outcome monitoring. And if you have that, then you can have a successful pancreatic surgery program. Thank you.
Thank you, Dr. Kalay. I think very informative for most of us who are planning to start robotic in the early phase. And I think house is open, sir.
Congratulations, Kalay, for an excellent program. So after 6 years, 7 years, 7th year of your program, which cases of pancreatic cancers do you simply not consider for robotic surgery? Are there any indications for not considering for? So I consider now you with the felicity with which you handle all peripancreatic vessels, there is no doubt that sky is the limit as far as what you can achieve. So now tell us about your limitations or robotic surgery's limitations, if any.
Sir, as of now, the contraindication is when there's venous involvement. Because personally, we still feel that when we do robotic venous reconstruction, the need for graft is slightly more, because we won't be able to achieve the similar type of mobilization which we can do in open surgery, where we can completely do a proper cattle brush. So what we do actually in robotic surgery is partial. So that's why as of now we are not taking the cases where there's venous involvement, because there you might kind of have a disadvantage of not doing a end-to-end and using a graft if you have to do a robotic. But intra-op we are seeing a venous involvement, and because most of the cases where pre-op imaging wise no venous involvement, but intra-op you see often it will be a minor resection, that we go ahead. But pre-operatively when there's venous involvement, as of now we are not taking up for robotic surgery.
Do you think that if you always used a graft as opposed to end-to-end anastomosis, you may actually end up dissecting less and less in the HDL and into the proximal, jejunal and small bowel mesentery, and decrease the amount of lymphoria, and improve the outcomes. Do you think? Because in some cases where we are forced to use a patch,
yes,
where the actual loss is at an area where the confluence happens, we find that the drainage, even serous drainage, is much less. The lymphoria never seems to happen, whereas when we do our end-to-end, we encounter more of these. This is my observation. Do you have any comments about that? I'm just suggesting that there may be a hidden benefit in putting a... Okay.
Need to analyze it.
Thank you very much.
Thank you.
Dr. Kala, since you are working in government hospital, so how the extra cost, who is paying? Is hospital only, or is patient is paying?
So I think that's one of the main advantage we have, because as of now the cost is, the patients don't have to pay anything extra unless they are taking a special ward. Even there the additional cost is only 50,000 extra, which is much lesser. I think that's one of the main advantage we have, and that will be an important limitation in other centers.
And one more question, you said case simulator and practice before that. Is there a defined time period is there for hours and?
So it's one is that's actually a scoring system. So you need to score in each of those skill tests. You need to score. If you are able to score with a shorter hours, it's fine. And then so that's the only mandatory part. The remaining things actually not mandatory, because the robotic, all these companies when they started, they were focusing more on the training. But unfortunately now the focus is more on the business. So they don't really tell you that you need to undergo all these 4 training steps. So I think it's important for us to make sure that we go through that, because if you skip, and then you will have definite problems in the initial cases. And this is more commonly happening now, because even the institute, they are not stressing upon this training pathways. Now they have found various ways of certifying surgeons, but that's not right. I think it's important we as a surgeon should make sure that we follow that training pathway so that we'll have good outcomes.
Thank you. Any other question from the house?